Okay, guys, I think we'll get started. So welcome to our first for the year update for practice nurses, GPs and pharmacists webinar from the Public Health Unit. So I'd like to begin by acknowledging the traditional owners of the lands on which we meet today and pay our respects to elders past, present and future, for they hold the memories, the traditions, the cultures and hopes of Aboriginal Australia. If you have any questions throughout today's session, please pop them in the Q&A chat box, and if we have time, we will try to answer these at the end. Any questions we don't get to, I will include the answers in an email when I send out the slides and this recording. We appreciate if you can complete the evaluation survey that will open when you leave the session. This will help to ensure we continue to provide relevant information for you. As I did mention, we will be recording today's session and we'll be able to provide a copy of the recording along with your certificate of attendance and the slides. These will be sent out to the email address you registered with within the next couple of weeks. As always, please be aware that each state has a different immunisation program governed by their state public health unit. So the information provided by the Queensland Health PHU may not be relevant to some people attending from other states. The information provided at this webinar is specific to Queensland, and we recommend that you check with your local state public health unit for localised information. All information provided in today's session is current as at today. Please refer to the PHU if you have any queries. Their contact number is 07 3624 1111. And today our presenter is Emily, a public health nurse from the Metro North Public Health Unit. And I'll over to you, Emily.
Thanks, Amy. I'll just share my screen. Can everyone see that, hopefully?
Yep, that looks good to me.
All right, thank you so much, Amy. Hi, everyone. Welcome to today's session. Thank you so much for attending, and thank you as well for all of the questions that you sent through to Amy as well. Amy's done the acknowledgement for us today, but I'll just pop that slide up as well. So thanks, Amy, for that. I just want to talk a little bit about what we're going to be discussing today. So there's quite a lot of content in this presentation of differing topics, and that's to sort of try and address all of the questions that you sent through to Amy. Some of the slides are quite full, but hopefully this presentation, when Amy sends it out to you, will be a little bit of a resource for you all. There's a little bit of repetition in the slides, particularly around RSV, because the bulk of the questions that we received from everyone was about RSV. So I've just tried to present a few different tools and a few different ways of looking at things, particularly around RSV. So we're going to talk obviously about RSV, a little bit about pertussis, some early information about the influenza program for this year, a little bit about catch-up, some updates around eligibility for Mpox and Shingrix, a little bit about preventing vaccination errors, vaccine management and storage, falling vaccination rates, some information about some updates to AIR and uploading to AIR, and then the last slide's just a reminder about the QUIP modules that are available for everybody online. Okay. So I'll start with RSV. So this has been a hot topic for us as immunisation providers, probably for the last sort of 6 months, and there's been some changes even in that short period of time. So essentially, initially, Queensland introduced the paediatric RSV prevention program just because of the statistics around RSV being the leading cause of hospitalisation in infants less than 6 months of age. The program now comprises of the Queensland-specific program and then the pregnancy vaccine that's just been brought into the National Immunisation Program in February. So the program essentially has two components. It's the free RSV pregnancy vaccine, and it's the nirsevimab monoclonal antibody for infants as well. Following the introduction of the RSV vaccine, there's obviously been some changes to the nirsevimab eligibility. And now there's sort of three probably main opportunities to protect babies from RSV for the mother in pregnancy, at birth, and in the second season, depending upon the risk profile of the baby. So this is probably the newest part of the program around RSV. So it's an RSV vaccine for pregnant women funded by the National Immunisation Program. Abrysvo is the only one that's TGA approved to be used in pregnant women, and it's recommended at 28 to 36 weeks, but can be given past that point. Generally, what NCIRS says is that there's no need to revaccinate it if it's given at less than 28 weeks. But if a mother is vaccinated sort of in error or something like that, less than 24 weeks, then the clinician, the baby's clinician, can consider nirsevimab for the baby once the baby's born. In terms of revaccination in subsequent pregnancies, which is something I know that we obviously do for pertussis, but we don't have any advice about that at the moment. We just need a little bit more data around that. We do know that maternal immunisation for RSV reduces the risk of severe RSV in babies less than 6 months of age by about 70%. It's not seasonal, so the vaccine should be offered all year round. Infants would not be considered to be protected for at least 2 weeks after maternal vaccination. So if mothers are vaccinated less than 2 weeks prior to birth, then nirsevimab is recommended. And just a note there that it's not recommended for breastfeeding or non-pregnant women. It's one dose IM in the deltoid, and importantly, it can be co-administered with other pregnancy vaccines, such as obviously the DTPA, influenza, and anti-D. And this might be particularly important if you've got vulnerable women or at-risk women who you're not quite sure whether they'll return. So it's good to know that all of those vaccines can be administered on the same visit. Okay. So I think we've just mentioned efficacy data. We still need some more safety and efficacy data around administration outside that registered period of 28 to 36 weeks. There's some really good resources now in the Australian Immunisation Handbook, the NCIRS, and also in the Queensland Health Paediatric Prevention Program website and clinical guidelines. There's a new flowchart that helps to determine nirsevimab eligibility, which might come up if babies who are indicated for nirsevimab have not received that in the hospital. Essentially, the eligibility in a nutshell is around all infants of mothers who did not receive the vaccine in pregnancy are indicated for monoclonal antibodies. At-risk children, so for example, children who have chronic lung disease, significant immunosuppression, etc. And then also some children, at-risk children, less than 24 months of age, and in their second season of RSV may also be eligible. So there's an appendix in the bottom link on that slide. There's an appendix around what is considered to be high risk and who would be indicated, which children would be indicated for monoclonal antibodies. I've just done a snip of this flow chart as well that is quite a nice, I think, representation or guide about which children should be receiving nirsevimab. So it's from the handbook, so the link is down the bottom there if that's helpful, hopefully. And there's a little bit of information there about which children are at risk as well. You might be already aware, if you've started to receive stock of this vaccine, that it is one that does need to be reconstituted. So I've just included a slide there with some instructions for reconstitution for you as well. So regarding the nirsevimab, any general practice, any vaccine service provider can provide the nirsevimab. It can be ordered through QIP, and also that would be the same for the maternal vaccine as well. Obviously, with the introduction of the Brisbane for the pregnant women, there's an expectation that probably there will be a reduction in the administration of the nirsevimab as more women become vaccinated going forward with the Brisbane. And the other vaccine that's now available is a vaccine for older adults called Arexvy. So, and then also the Brisbane is also available for older adults. These are both TGA approved but not funded. At this point in time, they're available on private script, but sort of no sort of plans at this point to put them on the National Immunisation Program. So there's no brand preference, so either of these vaccines can be given to older adults, just noting that the Arexvy cannot be given to pregnant women. The vaccine is recommended but not funded for everybody over 75 years. People from 60 with at-risk conditions, which mean that they're more at risk of RSV, Aboriginal and Torres Strait Islander people over 60, and then adults between 60 and 74 can consider the vaccine in conjunction with their healthcare provider. Again, it's a private script. It's a single dose, and at this point in time, no booster doses are recommended. And even if someone has had the RSV infection, once they recover, they are able to get the vaccine. That having the natural disease does not give you long-term protection to RSV. One of the questions we had was about the presentation of these vaccines. So they come in single packs. At this point in time, you would be delivered them in single boxes. Oh, there we go. No plan to add to the NIP as I just discussed. I thought this was a really helpful table from the NCIRS, or there's a link in the slide there. So I've just cut and pasted that one into here as well as a resource. Just explains the different available products and who they would be indicated for. So the two vaccines and the monoclonal antibodies, the nirsevimab. And the link to that document is on the left-hand side there. Recently, we here attended an NCRS website on RSV, and they included this slide, which we sort of thought was really useful. What's happened apparently in the US is with the introduction of these vaccines is there's been some brand confusion, unfortunately, and pregnant women have been getting the Arexvy unfortunately. So this is just a way of remembering, or some diagrammatical and kind of sound related ways of remembering the different vaccines, and who's indicated for which vaccine. So I hope that might be a little bit helpful too for you in your practice, now that there could potentially be 3 different products for RSV in your fridges. And the link to the presentation by the NCRS, which is where this is snipped from, is down the bottom of the slide as well. So we're going to leave RSV now and move on to pertussis. The reason I've included this slide is probably you're already aware that there's been significantly high rates of pertussis notifications in Queensland, probably over the past 12 to 18 months or so. The rates that have been reported in Queensland have been the highest ever on record. And I just included this slide because I think it's just important to remind everybody that vaccination is the best prevention for pertussis or whooping cough, and particularly to prevent vulnerable infants less than 6 months of age. So in terms of recommendations, with pertussis, obviously the vaccination is funded, Boostrix and Adacel funded for pregnant women. But it is recommended for women who have recently given birth but weren't vaccinated whilst they were pregnant and haven't had a booster dose in the last 10 years. It's also recommended for a number of different other cohorts. So every 10 years, booster doses. So healthcare, childcare, household contacts and carers of infants less than 6 months of age, and those 65 years of over if they haven't had a vaccine within the past 10 years is currently the recommendation in the handbook. Unfortunately, that's not funded though, so that would have to be privately purchased, but still obviously recommended for anyone that's going to have contact with incompletely vaccinated children, and particularly less than 6 months of age and pregnant women in the last month of pregnancy. I did a bit of a Google search before this presentation just to check how much Boostrix vaccine is, but you probably know that better than me. I think it's around $30 to $40 to purchase on a script, on a private script. Sometimes you can get some of that money back from if people have private health cover, which I know is not everybody, but that's just one other consideration. It's really, I think, good, particularly as we've had this big resurgence, to use the opportunity to discuss pertussis vaccination when you're seeing your families, and just have that in the back of your mind when you see a patient, just to check whether or not they've had a recent pertussis-containing vaccine or a pertussis-containing vaccine in the last 10 years. This is obviously over and above the funded program for infants and in the school immunisation program as well. One of the other questions we had was about shingles eligibility. So there's been a slight update to the eligibility for shingles. I think it was probably it could have been about 6 or maybe a little bit longer than 6, maybe 6 to 12 months ago. So the program advice for vaccination providers has also been updated as well. And there's a link to this in the slide, but I've just included this table with that updated eligibility, which is sort of around at-risk people, less than 65 or less than 50 years of age. And obviously there's some information in there with regard to the interval between the 2 doses. We've had quite a few questions at the Public Health Unit around a greater than 6 month interval, for example, but there's no need to start the course again if someone comes into you 8 months after their first dose or something like that, just to continue on where you left off. That's fine. So the link to that resources in the top of that slide as well. Sort of while we're on adults, I just thought I'd add a little bit of information in about adult catch-up. We'll talk about catch-up with children as well a little bit further on. But sometimes the adult catch-up is forgotten, and often adults do need catch-up too. Things to consider with adult catch-up is their age, any risk conditions, number of previous doses of vaccines received, particularly pneumococcal doses, but potentially other ones such as Shingrix and pertussis, as we were just discussing. So I've just popped in this slide just a quick example of someone that you might have in your practice and who need catch-up for adult vaccines. For example, an Aboriginal lady at 66 might need a Prevnar and a Shingrix, and then 2 to 6 months later a Shingrix, and then 12 months from that a Pneumovax 23 and a second dose 5 years later. And then I've popped down the bottom, consider a pertussis, but obviously that's not funded. And when you get your flu vaccines, obviously you would include flu vaccines in a catch-up for everybody over 6 months of age as well. That's just a quick example about an adult catch-up that you might get. Pneumococcal, we'll talk about the pneumococcal vaccines in a little bit. They can be a bit tricky, so if you need any help with the pneumococcal vaccines, just give us a call, we can assist you. There's a few different resources that we can point you towards as well, including the NCIRS documents, frequently asked questions and things like that. So I just wanted to pop in an update about Mpox vaccine eligibility. So initially when this program commenced, there was only certain providers that were providing Mpox vaccines, but now any VSP can order Mpox vaccine using the usual ordering process. Just recently, probably at the end of last year, there was an expanded eligibility due to some cases, some additional cases sort of in different parts of the world. So anyone, regardless of sexual orientation or gender identity, who may undertake risky sexual activities during travel to other countries, particularly where there's transmission of the clade 1, can have pre-travel Mpox funded. So just something to consider if any of your patients are travelling as well. If you have any questions about Mpox specifically, there's some information on the Queensland Health Mpox website. There's also some documentation from ATAGI, and also if you yourself don't give Mpox vaccines at your service, you can always refer your patients to the Mpox Vaccination Centre, find a map on the Queensland Health website, and you just pop in your, or the patient can just pop in their postcode, and it comes up with the closest vaccination centres. So we'll just move into some information about catch-up in general. So probably the bulk of our calls to the public health unit about immunisation, or probably more than half, or about half, are about catch-up for children from overseas. It is really good to have this skill, and we're more than happy to assist you and support you in developing this skill and giving you some tips and ideas. The next couple of slides, though, have some tips and ideas, general catch-up guide that essentially comes straight from the catch-up section of the handbook. I know that catch-up does take a lot of time, but if you can sort of sit down and get a little bit of time to do these, it can make it a little bit easier and less stressful for you. And we're also here to help as well, so we can, if you work out a catch-up and you're not sure, we're more than happy to have a chat to you and work it through with you over the phone. Essentially, when planning a catch-up, the intervals may not be the same as the standard schedule on the NIP. sometimes they can be shorter or longer, but primarily shorter because you're trying to catch people up as quick as possible. So the minimum interval might be observed rather than what's on the standard schedule. One of the questions we sometimes get is, do you need to wait 4 weeks between a live vaccine and an inactivated vaccine? And generally, no, you don't. You can either give the live vaccine and the inactivated vaccine on the same day. You can give 2 live vaccines on the same day, or 4 weeks apart, or you can give a live vaccine such as MMR today and one next week if you need to. So that might come into play, for example, where you perhaps have a vaccine hesitant family or something like that that only want to give a couple of vaccines at a time or something like that, even if the child is overdue for more than that. So it's important to note that if you don't have written reputable records, then the vaccine, you just start again. So if you don't have reputable records and no evidence, then you just need to do the catch up as though those vaccines have not been received. The older the child gets, the less number of doses are required. For example, that would be for Prevnar 13, for example. And then there's a couple of catch-ups vaccines that don't require catch-up. So rotavirus vaccine, and there's no need to start the schedule again. So even if it's been some time since someone's had a first or second dose and they need a third, there's no kind of maximum interval. The only sort of exceptions to that would be cholera, which we don't routinely sort of use in our daily practice, or most people wouldn't, and then sometimes rabies vaccines as well. Okay. So sorry, this slide's a little bit squished in together. So sometimes what happens too is that when children come from overseas, the intervals that we would usually consider to be best practice here in Australia are not observed. And so if that's the case, vaccines are considered to be invalid, and another dose should be given a correct interval from the previous valid dose, apart from live vaccines where you do need to wait 4 weeks from the invalid dose. You still need to record the invalid doses on air as well. Another tip or thing to remember with regard to catch-up is that in most circumstances, previous infection is not a contraindication to vaccination. And so often it's just more practical to offer vaccination rather than laboratory testing. There is, though, obviously the option for the GP to document and upload a natural immunity form as well, if it's appropriate. We've had a couple of questions around whether or not it's okay to vaccinate in Australia according to an overseas schedule, and the answer is no. We always vaccinate according to the Australian schedule here, even if children are from overseas and started on a different schedule. Just from time to time, parents want to continue on with the schedule from overseas, but we always obviously vaccinate according to Australian schedule and Australian Immunisation Handbook guidelines. A lot of calls lately, I think probably anecdotally more so than we've received previously, around customised schedules. And what we mean by that is a little bit like what we were talking about before, where a parent is willing to have something, but not everything. So it's okay to customise a schedule using the available vaccines. So in other words, if you can order it through Quip, you can use it for catch-up. So say, for example, parents only want their 2-month-old baby to have DTP. You might like to use an infant Rex. That's for example, that's what's available through the immunisation program. And we always say that some protection is better than none. and we know that it takes a lot of working sometimes with parents and education and that sort of thing. And so, you know, I think it's a good thing to sort of start with something that the parent feels happy with and then move on from there. If you've got any questions about that, please give us a call. More than happy to have a chat to you about that. If parents want vaccines that is not sort of part of the routine schedule, but they're available privately, then that's okay. It's just that they can't have, you know, obviously anything that's not available via QUIP, as long as obviously all of the rules are met around intervals, age recommendations, and that sort of thing as well. But we can help with that too if you're not quite sure. I've just popped a little bit of information at the bottom of this slide about some available resources. So probably many of you are aware that Paul, my colleague, some years ago developed some catch-up worksheets for over 10 and under 10. So there's two different worksheets. So Paul regularly keeps those updated. So if you would like copies of those, please email us and we can send them through to you, and you can have a look and have a go and see whether you think they're useful for you. There's obviously a couple of online tools that may be of assistance to you. So there's the catch-up calculator, which many of you have used, I'm sure, and then the pneumococcal vaccination tool as well. So the catch-up calculator sometimes can cause a little bit of confusion just because it lists out all of the different available vaccines for one antigen, for example. So if you're not quite sure when you've used that calculator which vaccine you should be giving, more than happy, again, to give us a call and we can have a chat to you about that as well. I just wanted to give you, or talk about giving more than one vaccine as at one visit. So it's important to give the vaccines as per the schedule. Obviously, for Bexsero, there are alternatives to that as well, but we do encourage giving the vaccines as per the schedule, and obviously using paracetamol prophylactically for the Bexsero. Just a couple of tips around giving more than one vaccine at visit. We often suggest that you give the most painful vaccine last, obviously, which hopefully would help with pain response. And then Bexsero and Prevnar should be in separate limbs as well. And then vaccination sites generally would be recommended in the handbook of 2.5 centimetres apart in the deltoid. So sort of if you draw that triangle, you can do the upper sort of and the lower deltoid as well. At the 12 months of age schedule point, the deltoid is preferred over the lower limb for Bexsero. There's a couple of different little diagrams around vaccination sites for childhood vaccination. I've included one of them there for you in the link that might help as well. Again, if you've got any questions about this, please give us a call. I'm more than happy to work through with you some of these issues or provide you with support around some of these, sort of giving multiple vaccines at a time. It's also important, it may come into play when you're doing a catch-up, and particularly if you're concerned that you have a family that might not come back or they might not have the means to return. It's sort of an important thing to remember for opportunistic vaccination as well. While you've got everybody there, give what you can, essentially. The next couple of slides are about vaccination for kiddies that are travelling. So we do get a lot of calls about this as well. Lots of families go overseas, and I'm assuming that you would get lots of requests to vaccinate children, so they've got some protection before they're going overseas. In most circumstances, early vaccination is possible as long as intervals and age recommendations are met. However, that could mean that a repeat dose of an antigen is required when a child returns home. So, for example, the example that's on this slide is about the 2, 4 and 6 vaccines. So you can provide those vaccines on this 2, 4 and 6 schedule point early, although you may, again, the child may need to come back when they get back from overseas for the Hep B part of that infant Rex hexa, for example, because you potentially, depending on how early you give it, the rules around hepatitis B may not be met, and so a repeat dose would be required. Yeah, and just to note, the last part of that makes reference to the fact that if that's the case, with the hepatitis B intervals not being valid, then the parent would need to be purchasing the paediatric hepatitis B dose on return from travel. So often we also get questions around that 12-month schedule point. So if you can give the vaccines prior to 11 months of age, but then they would need to still be repeated as well. But for example, MMR vaccines can be given from 6 months of age, which would be recommended because obviously depending on where children are going, it would be important to be covered for measles, for example. We would usually, as long as those intervals and age recommendations are met and the parents are aware, if it's required, that they would need to return for repeat doses, we would definitely recommend that children are vaccinated prior to travel where they can be, just so that they've got some protection during that time. And if possible, I know this can be a bit tricky depending on when people present to you, but we do obviously want at least sort of 10 to 14 days prior to travel for the child to develop immunity as well, if possible. I just included this slide as well. It's a little bit tricky virtually to talk about catch-up, but I just thought this might be a little bit helpful. This slide just about sort of how do we work out catch-up. So essentially, this slide talks about a child who's moved from overseas. There's documented evidence of previous vaccination history. And then from that documented evidence, a catch-up is determined. Firstly, looking at which antigens are required and how many doses of those antigens, and then working out a schedule ensuring the minimum intervals and the minimum age going forward. So again, if you work out a catch-up like that, if you have a scenario like that, you can either email us through with what you've come up with, or you can give us a call and we can help you and make sure that that you feel confident with the catch-up that you've documented. This one's probably a fairly simple example, I hear you say, and that's true. I did just put down a simple example. I know that some of these can be really, really complex, particularly from countries where there's vaccines given quite different to ours, or potentially not recognised here in Australia. So, for example, MR vaccines or different sort of meningococcal vaccines, polysaccharide vaccines, for example, that may not be accepted in Australia. So I do understand that this can become very complex. So again, please reach out and we're here to support you. So I know this is what you've all been waiting for, updates about the flu program this year. So essentially it's going to run in the same way as it did last year. And it will commence on March the 1st when the stock is expected to become available, and conclude on the 30th of September. Some vaccines will be available on the 1st of March, but we're not expecting a full sort of supply until April. And because of the way things are distributed, not all providers will have stock by the 1st of March. As you can imagine, there's thousands of vaccine service providers to receive stock across the state. So, yeah, it'll start to be distributed, but maybe not everyone will have that stock by the 1st. Again, as I said, same as last year, providers can seek reimbursement for non-NIP eligible people to be vaccinated with flu vaccine up until the 31st of October. I know this can get really tricky for providers, but to try and make every effort to offer flu vaccines to everyone, and make sure that NIP eligible patients do receive their NIP vaccines and everyone else receives the private stock, and then that gets reimbursed to the VSP. There's just a kind of one-pager up on the Queensland Health website with this information there. So if hopefully that's helpful. My understanding is that the vaccines will be provided in, I think 10 packs this year. I do have that written somewhere. I'm pretty sure it's 10 packs this year. Yep, FluAd Quad, Vaxi-Grip, Tetra and FluVax will be delivered in 10 packs. Now, I just popped down right at the bottom of this slide a link to a research trial that's happening. One of our questions that we received through Amy was about a combination COVID flu vaccine. To my knowledge, there's nothing imminent, but there is research around this, so watch this space. Yeah, the research for this at the Mater here in Brisbane was launched late last year around flu COVID combination vaccines. Just a quick pneumococcal update. That was one of the questions we received as well. The pneumococcal vaccination for Australia is currently under review, so there'll be consideration given in that review with regard to some of those newer vaccines with additional number of valents in them than we currently have with the Prevnar 13. So again, that's another situation to watch this space and see what the outcome of that review is going to be. Just a little bit about the flu composition this year in case you're interested for the trivalent vaccines. And I just put a bit of red pen down the bottom of this slide just to ensure to start thinking about the capacity of your fridges and making sure that you can safely store all your usual vaccines and the flu vaccines during flu season. To start thinking about that now. The next couple of slides are about Medicare and other eligibility. So essentially everyone living in Australia is eligible for NIP vaccines. Generally, overseas students who are studying or visitors are not eligible. The exception to that is the meningococcal B program, so the Bexero program is not linked to Medicare status, so that's because it's a Queensland government program rather than a NIP program. Please make sure that you, whatever vaccinations you're doing, even with overseas people who might not have got a Medicare card just yet or something like that, please enter the vaccination episode into AIR with as much information that you have, and then that way there'll be matching within AIR Sometimes we get a bit stuck with two different records for the same child, one with a Medicare number and one without. So this slide is probably particularly about MMR, and I did touch on that just before when we were talking about giving vaccines early. So I'm sure you're aware that we've had a number of cases of measles in Australia over the past few months from returned travellers. There's been cases around the world, Pakistan, India, Thailand, Philippines. There's been outbreaks in the Midlands of England. There's been outbreaks in Texas. So really important to make sure everybody's up to date with their MMR vaccine. Anyone born after 1966 who don't have documented doses of vaccine should receive 2 4 weeks apart. As I said before, MMR can be given from 6 months of age and does not need to be repeated if it's given from 11 months of age. So I just thought I'd pop a little bit about preventing errors, preventing vaccination errors. Now, obviously we're all human, and from time to time we all make errors, and we're more than happy to support you if there's an issue that comes up and there's an error being identified. We can assist you with what sort of the next steps are and that sort of thing. But to try and prevent the errors, I just thought I'd put a little bit of a slide together around the pre-vaccination process. So the right person, the right vaccine, the right minimum intervals, the right age, use of the pre-vaccination checklist. If you come up on that checklist with contraindications and precautions, there's a nice little table in the handbook about how you might proceed with vaccination for that particular person. If you need to seek further advice, then you can talk to the specialist immunisation service or sort of more like infectious diseases team at your local tertiary hospital, or we can assist you as well depending on the situation. And then the other thing is just to sort of, if you're not quite sure, just reach out to either a colleague, or we can assist you as well prior to giving the vaccine. More than happy to help you there too. And just to note that if an error is made, that obviously they're now reported. Vaccine administration errors are now need to be reported via the AFI form. So it's a little bit confusing, but if you just use the AFI form, and down the bottom of the first page, there's a tick box. It's either vaccine administration error or AFI to tick on there. So now just a quick couple of slides about vaccine management and storage. And of course, it wouldn't really be an immunisation session unless we mentioned cold chain. I've just documented on this slide a few common issues that we find when we're investigating cold chain breaches together with all of you. So I'm sure I know you know that vaccines are delicate biological substances that can be destroyed if frozen or subject to heat or light. So a few issues that we've come across is essentially unable to access temperature monitoring. So manual charts not being completed, or the data logger hasn't been recording. So when we sort of request temperature records, we're unable to access them, or the practice is unable to access them. Use of domestic fridges when a breach occurs, if a usual fridge is malfunctioning, no monitoring in eskies, and vaccines not being isolated, resulting in affected vaccines given to patients. So just a few things to keep in mind. So in terms of just a few tips as well, we do suggest that a primary person is responsible at each vaccine service provider for vaccine management. But having said that, it is really important to make sure that you have a number of other people trained up in vaccine management and storage in the instance that someone might be on unplanned leave or go on holidays or something like that. We've had a couple of instances where only one person in the practice knows how to download the data logger, and that person is on leave and a cold chain breach occurs, and it takes a couple of days to to get that data logger information, which means that it just takes a lot longer to resolve the breach and a lot longer for you guys to sort of get up and running with vaccinations again. It's also important to make sure that every fridge has a data logger, that the fridge temperatures are monitored on every day that the practice is open, regular audits, up-to-date VMPs, and just a comment there about the Strive for 5 guidelines will be updated in March this year. So again, watch out for that coming. If you've got any questions about vaccine management and storage, we're more than happy to assist. There will be some updates around the template for the vaccine management protocol, and there is some consideration given at the moment to looking for a little bit of an alternative way of doing those vaccine management protocols and submitting them to the public health unit. So we'll keep you informed about that. We're doing a little bit of work to try and make that process a little bit easier. So now on to vaccination rates. So you're probably aware that vaccination rates have been falling around the world, and including Australia post-COVID. For children, the percentage of children considered fully vaccinated is reducing, as well as the proportion of children vaccinated on time. That's also decreasing. And that's also the case in adolescent vaccination rates as well. Some more information about that can be found in a recent report that's been done by the NCIRS, and I've just popped the link to that in there for you. So there's a few things that's going on in this space, but I guess the question is what can be done, and most importantly, there's some work around what the barriers might be to vaccines. We should also recognise the importance of the trusted health professionals, so that's you guys, in combating vaccine hesitancy and falling vaccination rates. So often you guys would have a really good relationship with someone and sort of more likely to be able to have a chat to them about vaccines. I've just popped a link there about the sharing knowledge about immunisation resources. It's a really good website there. It's evidence-based. There's lots of resources to support health professionals in having discussions about vaccination or immunisation. So just a couple of last few slides around air. So there's been a lot of changes to air probably in the last 12 to 18 months as well. And we're now obviously being asked to indicate the funding program for each vaccine that we upload to air. So sometimes it's a mandatory field, sometimes it isn't. But there's a couple of examples on this slide to help you about which program to choose when you're uploading the vaccines. It's also important to remember that sometimes, just to double check that the vaccines that you upload using your software have gone on to air. We've just had a few calls lately where vaccines have been given according to patient documentation or reports, but they've not been uploaded to air. So just to remember that. I just thought I'd put a couple of slides in with some snips from AIR. So AIR has recently introduced the antenatal indicator, which is going to assist with data around vaccines given in pregnancy, given that there's a number now, 3 or so. So it's just about clicking yes or no every time that you do an encounter on Proda there. I also had a question come through around some vaccines that are not part of the National Immunisation Program not coming onto air. So essentially, the way that you can select those vaccines is by clicking on Other in the schedule part of the record encounter screen, and then that will allow those other vaccines that are not as part of the NIP to come up, and you can enter them and upload them. And that's through the Proda system. I'm not quite sure whether that's the same for your practice software, but if you have some trouble with air, sometimes it's easier and you've got more, you're able to easily solve a problem if you go through via Proda as well. So that's just one tip. If you think there's an issue from, that something's not coming up properly, sometimes if you log into Proda directly, you can identify that issue a little bit easier. But we can also help you with that as well, because obviously we only use Proda. We don't have any sort of practice software here at Public Health Unit. So we can help you with navigating around Proda if you need any help. Or obviously you can call the Australian Immunisation Register as well. Some other troubleshooting as well is just, I think, about the immunisation details on the air screen when you log into Proda. So sometimes when you generate a PDF rather than clicking on the drop-down box, any vaccines that have not been accepted will not be included in that PDF document. So if you've got any issues, it's really good to use to click on that arrow, that down arrow, or click in that pale green sort of box where it says immunisation history, and then the whole history will come up and the status of each vaccine will come up, and you'll be able to identify if there's any issues that way. For example, if a vaccine has not been accepted, for example, because of a duplicate antigen code or incorrect dose numbers or something like that. Again, we can help you with that if you're finding that there's any issues with that. And then the last slide I've got today is just a reminder about the online immunisation training, which is free. There's 4 courses there that may be of interest, particularly to new staff, that you might like to refer new staff to, or even as a bit of a refresher for anyone online who's quite experienced. These are the references for today, as well as all of the links throughout the presentation. So when you get the presentation, you'll be able to copy and paste those links as well. So I think that's probably all I have, which is lucky because I think we're right on time. Amy, over to you.
Yep, thank you. We've got a couple of questions.
Okay.
So excuse my croaky voice, everyone. The first question is, how long do we think, and excuse me if I pronounce this wrong, Arexvy, etc., gives for immunity, currently noting no booster currently indicated, please?
Oh, I'm sorry, I don't know the answer to that question. I'd have to double check about that one. I'm sorry. I can do that when Amy sends out the presentations.
Yep. Okay. The next question is, pertussis vaccine used to be recommended for health professionals and family members every 5 years if they are around babies. Now the recommendation is 10 years. Has the vaccine shown to provide longer term protection?
That vaccine it does wane over time. It's a acellular pertussis, which is different to the one that for example, I might have had when I was a child, which was a whole cell one. So the vaccine is still wanes over time, definitely. But that is the recommendation. In the handbook, it is every 10 years for a booster dose. Noting that I guess DTPA can be one of those ones that does cause injection site reactions. Following doses can cause injection site reactions. But yes, that I know what you mean. There was a time when it was every 5 years. Now, just also noting that was prior to the vaccination in pregnancy program we have, and also prior, if I recall correctly, prior to the introduction of the 18-month DTPA booster. So we have had some scheduling changes and more opportunities to vaccinate for pertussis since then and protect vulnerable babies.
Okay.
If that's not answered the question, please let me know, and I can answer it differently when we send out the PowerPoint.
No problems. Next question, just wondering whether you would prefer Bexsero at 6 weeks or 8 weeks?
So it's okay. You can just give it as per when you're giving the other vaccines. So or obviously you can give it with an interval as well. There's no preference.
Okay. And the last question, why do we now need to apply for Q fever skin test and the Q fever vaccine, as before we just ordered it from our vaccine provider?
I'm so sorry that I don't know the answer to that, because Q fever vaccine is a private vaccine. So it's with regard to the distribution and ordering of that vaccine, I'm not quite sure what the changes have been around that, but I can look into that if you like. But perhaps talking to the manufacturer might be the best way forward with that question.
Okay. Well, that's all the questions that have been put through. So thanks everyone for joining. And as we mentioned, the copy of the recording and the slides and the answers to the couple of questions that Emily was unable to answer now will be sent through in the next couple of weeks. And again, if you could please complete the survey that'll pop up when you leave this session, just to make sure that we continue to provide relevant information for you guys. The next PHU immunisation update is planned for May, so keep an eye out on your inbox for the EDM about that and how to register. That'll be coming out generally around 6 to 8 weeks prior to the date of the webinar. So yeah, thanks so much, Emily, for being here today, and have a great afternoon, everyone.
Thanks, Amy. Thanks, everybody. See you later. Bye.
Thanks, bye.